and welcome to our show, Healthy Living. I'm Kaylene Cornell, Health Education Coordinator for the Purchase District Health Department. Asthma is one of the leading chronic childhood diseases in the United States, as well as in Kentucky and here in our area. According to the Department of Health and Human Resources, asthma affects over 4 million children. It is also a leading cause of school absences, which accounts for over 10 million missed school days annually. Asthma is a chronic inflammatory disease of the airways. In other words, it's a long-term disease which can't be cured. However, it can be managed and kept in control. Today I'm joined with Dr. Bradley Rankin from the Family Allergy and Asthma Clinic, and we are going to discuss asthma today. Dr. Rankin, first of all, thank you for coming.
Well,
this
thank
is
you
great.
Thank you for having me here.
Sure. We definitely have the asthma in our area. Before we talk about asthma, could you talk a little bit about your clinic and the work that you do there, and then talk about the healthy airways of how our air does move through the airways without problems?
Sure. We see adults and children with asthma and other allergic diseases. Thinking about your question, I think we spend a lot of time with educating patients about their medications that we choose for them, and because it's very important to understand the differences, and it can be very complex and overwhelming. We also take a strong look at the environment, in terms of allergens, as well as irritants, and then infection issues, and we try to go a comprehensive approach where we're going for avoidance measures where we can decrease medication requirements and go for healthy living. And then we also offer allergy injections to some patients, which is our form of immunotherapy that can help some patients with asthma. Mm-hmm. Now, as far as healthy lungs, how they work, our lungs are there to provide oxygen for energy for our bodies and to expel carbon dioxide. In the normal life of an adult or child, we should be really unaware of our breathing, and if it's not obstructed. Now, we might with extreme exercise, especially until we get in better shape or depending on the level, but we really shouldn't be aware of any obstruction or any tightness or anything that we would associate with asthma. We should just take it for granted and not give it a thought.
Sure, yeah. So with asthma, then, what does cause that hard breathing?
Well, there's 3 different factors. The classic one is bronchoconstriction, and our airways are surrounded by smooth muscle cells, and what happens is that when those smooth muscle cells bronchoconstrict and tighten up, that decreases the size of our airways, and that makes our lungs less efficient, so we have to breathe faster to do the same amount of work which we have to do to stay alive. And that's the type of process that a bronchodilator may help. But also, as asthma progresses, there can be swelling of the lining of the airway, and that can decrease the size of the lumen of the airway and create the same problem. And it's a little bit more difficult to treat. So that's why often steroids are needed. And then finally, while there's classically scant mucus production with asthma during exacerbations, those secretions can accumulate in the airway and also cause airway narrowing. And so those 3 processes can all lead to smaller airways and therefore the symptoms of asthma.
Sure, yeah. So when all of these are going on, what would you say are the 4 main symptoms that would be kind of a red flag of there's some problems?
Well, the 4 main symptoms of asthma are recurrent cough, wheeze, shortness of breath, and chest tightness. And everybody thinks that, well, you have to have all 4 and everything before it's asthma. It can often be one symptom, and if it's one symptom, most often it's a cough. And that patient can like go in the emergency room with a cough, and can have a normal lung exam, sometimes normal lung function. It's a little bit more difficult to diagnose. The other thing is that like a viral infection in an infant or small child can have wheezing, but it's not necessarily asthma at the time. And we have ways that we try to predict who's going to develop persistent asthma. And certainly not all that wheezes is asthma. An adult with congestive heart failure, for example, can have wheezing by exam. But if it's recurrent problems, especially triggered by exercise, which we are going to talk about, worse in the middle of the night, and it just keeps going, then we consider a diagnosis of asthma.
Sure, yeah, more of a pattern there.
Yes.
I think people do identify asthma with wheezing, and I have even heard, someone say, well, they don't have asthma because they're not wheezing. And,
right.
So I think people, they don't necessarily pick up on the fact where if someone's coughing a lot, that is a sign, and that's something that you need to be, aware of.
The other thing to consider with wheezing is it takes air it takes movement of air to wheeze. And so a patient during an exacerbation can have decreased, less wheezing and more problems, because again it takes air. So just as an isolated finding, if a patient is doing a lot of wheezing, they're moving air enough to wheeze, and without any other information, if their wheezing decreases, it can be a sign of worsening asthma, or asthma becoming worse.
Sure.
So you have to take a look at the entire patient and what's going on before you can make that assessment.
Yeah, yeah. One of the evaluation tools that has been science-based that many physicians do use is the ACT. What is that, and why would we want to use that too?
Sure. Well, the ACT is the asthma control test, and it's a very it's just 5 questions. The 5 are like this on this one page here. So if you can walk into your physician's office or anywhere or any time, and it will ask you the degree, of severity 1 through 5 of things like activity, how often you're using your rescue inhaler, sleep patterns, episodes of shortness of breath. Then finally, it's ask you, what is your level of control? And interestingly, you can ask patients or parents of asthmatic patients, well, is your asthma in good control? And they'll often say, oh, yes, it's in good control. But when you start looking at all these different factors, oftentimes their asthma is not in good control. So this is a reproducible way where if your number is above 19 or 20, you're in pretty good shape. Now, in our office, we always look at the individual components, and we always ask in between exams or office visits if they've been to the emergency room or the hospital in between, or if they've received oral steroids for an exacerbation. So all of those are important, but this is a very reproducible instrument, and it's very quick and easy to answer, and it is very helpful.
Sure, yeah.
Sure is.
And I think people kind of get used to where their health status is. It's like, well, they're not sleeping through the night, but they're used to that. So,
Correct.
they don't think of that as something unusual, So that tool then would kind of show that red flag, if they answer it.
Yes, and we see that all the time in children, because certainly a lot of children don't know any different. They don't know what it's like to breathe through their nose until it's no longer obstructed. They can't remember when it wasn't. So, you look at the whole picture again. Of those, the most sensitive thing, or if you had one question to ask them, is how often are you using your rescue inhaler, and if they're using it as needed. Now, prior to exercise does not count, but that. If you had one of those questions, it would be that. And if they're saying, less than twice a week during the day or per month in the middle of the night, their control is probably pretty good.
Sure, yeah. When we think of an asthmatic who is really in control, what would that golden standard? What should that asthmatic really look at for you know, being in control? What does that mean?
Well, it differs from each patient. Sometimes an improvement in control is staying out of the emergency room, or sometimes it's being able to work. But if they're sleeping through the night and they're functioning at school or work or play, and they're exercising fairly well with what they want to do, then they're in fairly good control. Now, they're still at risk of having problems if they've been in the emergency room even 6 months back. You know, so we do look at that. So they might be in good control in the office, but if they've been on a lot of steroids the previous 6 months or pulses of it, and they've been in the emergency room, we still classically don't consider that great control, because that dictates, again, how we treat it, which is the important thing.
Sure, yeah. Yeah, well, and I think too, you know, even for down to, you know, babies that are having, you know, problems, they want to be, you know, looking at that they're eating fine and they're, you know, acting, you know, normal. They're not, you're not hearing the grunting or the, you know, struggling. And so, now I know one thing, you know, there's different tiers of keeping in control with asthma, and one of them is medications. And I brought, we have a few here on the table of, you know, different medications. I think asthma is different than many other chronic diseases. You know, blood pressure, you take your blood pressure medicine whenever, you know, if it's once a day or twice a day, but you take it daily. Same thing with, you know, diabetes or whatever you have, it's pretty much, you take it, you know, daily. Asthma is, it's different. I mean, it has, you know, medicine where it's either you know, are puffing, or you're using a nebulizer, or you're taking medicine only when needed, you know, so it's very confusing. Can you talk about, first of all, the two main types? I think you've alluded to them earlier, but what are the two main types?
Yes. Well, the main thing that's causing asthma is inflammation. And inflammation or inflammatory cells get attracted to the lungs, and that leads to either what's called increased bronchial hyperresponsiveness, or just twitchy airways where they come in contact with certain irritants or allergens, and that triggers the symptoms. And also later, sometimes they can develop airway remodeling, where they have more of a fixed obstruction of their lungs. And of those, then, we treat with either controller or quick relief. And controller medications do not cure, as your introduction said, asthma, but they control asthma. And many of them, or most of them, are anti-inflammatory. They control inflammation in the airways. And the way I look at it, the analogy I use in the office, is that with controller medication, we're not mopping up, we're slowing the faucet down and slowing the water flow down. And that's what controllers are there for. It's this week is better than last week for having been on it. And we have some combination inhalers now that part of them can work within 5 minutes and relieve bronchoconstriction and improve shortness of breath. But in general, controller medications are for routine use. In Europe, they do it a little bit differently, and we may be doing it a little bit differently in years to come in the United States. But two main branches, they are either controller medication or quick relief. And again, an inhaled steroid would be the example of an anti-inflammatory medication. Singulair has anti-inflammatory properties as well, or any of the leukotriene modifiers. So they're controller, routinely given medications. And it sounds real easy. Just take this every day and everything's going to be fine. The problem is that they can stop taking most of them, and they can't tell the difference right away until they get a cold or come in contact with something. And so it can be very difficult to get them to remain on the medication, especially once they feel better. And the medications are a little bit difficult to use, which we'll see, and they are expensive, and they're not, you know, without side effects. and we do deal with those issues as well. But mainly people just get to feeling better and, oh, I don't need it anymore. Now, now the other medications are quick relief medications or rescue. And I like quick relief because rescue implies that way you're throwing them a life life thing running out in the water to save them, and we don't want them to wait until they're close to drowning.
Right.
We want them to use it as needed,
Yeah.
but clearly as needed. And these work generally, and we use them with most often with metered dose inhalers, and they're bronchodilators that relieve that constriction that I was talking about earlier. So an inhaler would work very quickly. 75% of its actions are done in 5 minutes, and the peak effects are in 1 hour, but they're gone in 4 to 6 hours. So it's strictly in this avenue and as needed medication. So our goal is the rule of twos, twice a week in the middle of the day or per month in the middle of the night. If they need more than that, not 1 week necessarily, but kind of on a routine basis, then we adjust at each office visit. We assess their level of control with the ACT test, lung functions, and we look at everything and we say, okay, you've been in good control for 3 months, so we're going to decrease your controller medication. Or you're not in great control, we're going to increase it, or we're going to hold your own and continue the same ones. So of those, usually albuterol, and there's many different brands of them. There's Perbuterol or Maxair. There's levalbuterol, which is one of the mirror images of albuterol, and it has its place. So those are rescuants, and the others are controllers. Another analogy that I find helpful, and since we're in the middle of football season, is that bronchodilator is like a 1-yard line tackle. A 1-yard line tackle stops a touchdown 100% of the time if it's a tackle. But they tend to score when they're on that end of the field in the red zone.
Yeah.
So it'll stop it. It'll stop from A to Z, from cause and effect. It will stop it, but they're right there. A controller medication that blocks inflammation, prevents inflammation from getting into the lungs in the first place, takes a little bit longer to work, and that's a 50-yard line tackle. And that's one way I describe it.
Yeah, I like that. It, because it is kind of confusing for folks to be prescribed this medicine and then this medicine and then get home and keep it straight. And if you don't understand what that controlling medicine is and why you should take it, like you said, they don't really see a difference if they miss it a day,
That's right.
But it definitely comes back at you. They need to keep on it.
And you can't take it for granted they're going to know it every time they come in. We have to continually reinforce and reassess their understanding. And then with us, we do allergy skin test. It's a couple of hour appointment at times, and it's hard to get everything done in that time, but we do the best we can, and then we'll see them back and reinforce what they've been taught. Of course, we have a team approach. It's not just from me. And so there's a lot of education involved.
Yeah, it is. And I think that's why it takes not just one time. It takes each time coming in because they're learning, and you can only hear so much and retain that. And so that's what's great, to get that education each time.
And that's the importance of the emergency room, because they're at their work and they can listen, although they're probably stressed out more then, as well. So it kind of helps with both, being able to teach them when they're not sick, but they might listen more when they are. So it takes everybody.
Do you see that people are more concerned of it being a steroid, and athletes aren't supposed to take their steroids, and should we take? I mean, do you ever get anyone to comment about that?
Absolutely. In children, the main concern is growth. And across the board, inhaled steroids will change the shape of the growth curve in the first year, by about 1/2 an inch. And it's not cumulative. Each of the other years they do fine. And in general, they reach their adult height. But parents are always concerned about that, and I know height is important. I mean, I'm about 6 feet, and I'm pretty average. I know what it feels like to walk into a room with a bunch of basketball players, and you're looking up and so on. But it really controlling asthma, which generally goes well, but not always. The mortality from asthma has been steady since 1996, and at just under 4,000 deaths per year, which pales in comparison to, say, cigarette smoke, which, as you know, is about 400,000 deaths per year in the United States. But most of those deaths are fortunately in adults, but 90% of the time they're preventable.
Yeah.
So it's not like leukemia or certain forms of leukemia. They've got good cures for that now, but they're preventable. So, but with any medication, there's always benefits and risks. And sometimes we're pretty sure a patient has asthma, and we can treat them with an inhaled steroid. And sometimes we don't need to treat them forever. It's not like once we start them on that we have to continue it, forever.
Yeah.
But that can be a perception, and they may.
Yeah.
But there's good studies that even in children who are having wheezing without asthma, you can treat them with an inhaled steroid. They will improve with it, and you can withdraw it later. But that's the main one in children. In adults, you've got the issue of cataracts, glaucoma, and adrenal suppression, and so forth, osteoporosis. So we try to use what's needed, but only use what's needed, and we just gradually try to taper to the minimum effective dose.
Sure. Yeah. Yeah. Because if you're not breathing well, you're just that's the #1 priority, and so you take the medicine of what will achieve that.
Correct.
So what about, we did mention about exercise and the medication. What do people see that works well for if they have exercise-induced asthma?
Exercise is a very common trigger of asthma. Not everybody that has exercise-induced bronchospasm has asthma. A lot of Olympic athletes have a different kind of form of it, but it affects up to 7% of the population, and it's more common with continuous exercise, like running or snow skiing, things like that, rather than stop or start activities. The test we do for it is we generally take a history and use medications, because 85% of the time a bronchodilator beforehand will help. When we do studies, we run them for 8 minutes, and we check lung function afterwards. So we're not talking fourth quarter of the second game here.
Yeah.
I mean it's pretty quick, and it's cough, wheeze during, especially after the activity. There are some non-pharmacological ways to treat it, and I would like to mention them first. First, important is adequate warm-up and cool down. If you're standing there listening to the coach, and the next thing you know you're doing wind sprints, you're going to have more problems than if you're allowed to jog and give time. But the classic treatment are the same short-acting bronchodilators, or your rescue medication. Again, usually a meter-dose inhaler, 2 to 3 puffs, 15 to 30 minutes before exercise, and 85% of the time that will take care of it. Now, another thing I have to tell, especially children and motivated athletes, especially during a game, is if they develop symptoms, they got to stop. And you do not want to be running with a bronchodilator in your hand and then use it and keep on going. That's the worst thing you can do. So you got to stop. And then you can, if you improve, there is something called a refractory period. Whether or not you use your bronchodilator at that time you can go back in and you'll do actually better than the first time. So stop if you have a problem, and then you can go back in sometimes and do fine, but don't push through it.
Yeah, yeah. Before we move into the environmental, and we just have a few minutes left, is the spacer. Now I know you know, there's different ones, but how does that improve, you know, the nebulizer or the inhaler? I'm sorry.
Well, the techniques are very important that they get correctly, and there's classic mistakes that we can predict that they'll make in terms of timing and speed. But what a spacer will do is it will slow the particles down. The larger particles will settle. The smaller desirable particles will float in the middle. And so you're blasting this blast into the spacer, and then you're breathing in very, very slowly right after that blast the smaller particles, and more will get into the lungs. Now, even with that technique and with perfect technique, only about 13 to 16% of the drug will get into the lungs. And that's fine. We don't worry about it. They put enough in there that's all you need. But probably the biggest function, it will decrease local side effects from an inhaled steroid. You know, if you think about it, with a rescue inhaler, if the first one doesn't work, they can take another one, and they're still going to get it in, even with subpar technique. But technique is always, you know, important. So it improves technique and increases airway absorption and decreases what ends up in the oropharynx, which is just swallowed and causes side effects.
Sure, yeah. So it really does help. And they're very easy, you know, to use by, you know, just hooking them up, and, you know, then you're able to, you know, just, I think they're large enough, you know, to make it, doesn't make it as easy to carry with, but if you can at least use them for like the steroid medicine, you know, the anti-inflammatory, probably would be better. The
larger they are, the better they work, actually. And so the old Inspirace that we were talking about earlier, it's got either 700 or 900 cc's of air in it, and that was their advantage. This is smaller, but you can clean it, and it's smaller and easier to use.
Sure. Yeah. Yeah. Well, there is another tool I know is the peak flow. Do you see many people using the peak flow anymore these days?
We are told to go ahead and try them. Studies are not that great, to be honest with you, in terms of them being able to assess it with a peak flow where they're not with symptoms. So and technically they have their problems, but I do find them helpful in certain patients, and we do use them. So with the asthma action plans that we do, oftentimes we'll use them with that. The key is, the idea behind it is that lung functions can drop before they are aware of it, and if you catch it, and that's one of the early warning signs, a decrease in the peak expiratory flow rate, then they can catch it and then go ahead and act on it and catch things earlier. But again, there's certain patients that do well with that, and some do not. I think it's less important, to be honest with you, than what we've talked about, teaching them how to use the inhalers and so on.
Well, we have covered a lot here, and it's been great information, and we haven't even covered a lot of other information that we're going to talk about. I think they're telling me that our time is done here, so thank you for coming, and I appreciate it. And I'm going to have you come back so we can talk more about triggers, and there's just a lot more that we can talk about asthma, if you would, please.
Absolutely, I'd be very happy to.
All right. Thank you for joining us. Keep in mind that asthma can be kept in control and be managed. So thank you for watching the show today.